Hello, my name is Reginald Tucker-Seeley, and I'm the Vice President of Health Equity at ZERO, the End of Prostate Cancer, and I'll be talking to you today about social determinants of health, health disparities, and cancer. I appreciate the invitation to this inaugural event, and so I'll give you a little bit of information about me first, and then I'll talk briefly about cancer disparities and social determinants of health, and then focus on measuring and reporting health disparities. So I'm currently the Vice President of Health Equity at ZERO, the End of Prostate Cancer. A few of my previous positions have included I was the Edward L. Schneider Chair and Assistant Professor of Gerontology at the Leonard Davis School of Gerontology at the University of Southern California, currently on a leave of absence from that position. I was an Assistant Professor of Social and Behavioral Sciences at the Center for Community-Based Research at the Dana-Farber Cancer Institute and the Harvard T.H. Chan School of Public Health, and also an RWJ Health Policy Fellow in 2017-2018 with a placement in the United States Senate. My education includes an undergraduate degree in accounting, a master's in human development and counseling, a master's degree in health and social behavior, a doctoral degree in society, human development and health, and postdoctoral training in cancer prevention and control. So what is ZERO? ZERO, the End of Prostate Cancer, is the leading national nonprofit with the mission to end prostate cancer. We advance research through our fundraising efforts, and we offer prostate cancer education and support services, including financial and psychosocial support. We pioneered mobile testing for prostate cancer, alerting men across the nation to life-saving information, and reducing prostate cancer mortality rates through early detection. And we continue to support early detection and free testing with local partners across the country. You can check out more information about our organization at zerocancer.org. So let's start with a discussion of cancer disparities. So for African American men, there are substantial disparities in prostate cancer. In particular, the number of new cases of prostate cancer are higher for African American men than compared to their white counterparts. African American men have higher mortality from prostate cancer, and this has been shown across multiple data sources. And so why do disparities in cancer exist? So cancer disparities reflect the interplay among many factors according to the National Cancer Institute, and these factors include the social determinants of health, but also environmental factors, clinical factors, biological factors, and all of those together contribute to disparities in cancer. So we'll start with a discussion of social determinants of health. While those of us in public health generally, and social epidemiology specifically, have been discussing social determinants of health for decades. But recently there have been many calls for the healthcare delivery system, and the cancer care delivery system in particular, to tackle the social determinants of health, to reduce healthcare costs, facilitate efficient healthcare utilization, and to address health disparities. A focus on social determinants of health recognizes that health does not only happen in the doctor's office, it also happens in our homes, in our schools, and in our communities. The World Health Organization's Commission on the Social Determinants of Health has defined social determinants of health as the conditions in which people are born, grow, live, work, and age, and the fundamental drivers of these conditions. Addressing social determinants of health is an effort to address the fundamental causes of health. That is, those upstream pathways through which resources such as money, knowledge, prestige, power, and beneficial social connections that protect health. The downstream manifestations of the impact of the social determinants of health on the community have been described as social needs. More specifically, these social needs are often considered the immediate barriers to good health and health care, and in particular cancer care for individuals. There have been several frameworks put forward to help explicate the many factors within the conditions where we live, learn, work, and age that influence our health behavior, and our health care, and to help us identify variables to measure in our studies and to identify areas to potentially intervene. Some of the models are ecological that highlight multiple levels, and others are pathway models that hypothesize the direction of the associations among factors in our social environment. Now, these frameworks have intuitive appeal because we know that across and within sociodemographic groups there are substantial differences in the environments in which individuals are born and grow up. And in our cities, the neighborhoods where we are often sorted by our sociodemographic characteristics can be vastly different and influence the choices for healthful behaviors. And also, those sociodemographic characteristics have shaped where we work and how we are aging. And it's these differences that influence our health behaviors, and how we navigate healthcare. Hill and colleagues introduced the NIA Health Disparities Research Framework to highlight important factors for health disparities research related to aging. Specifically, this framework provides an organizing structure for tracking progress, it explicates potential causal pathways, and highlights targets for interventions. The authors suggest that frameworks such as these facilitate our efforts to address health disparities in the aging population. In particular, this framework looks at factors from the biological level to the environmental level and encourage a life course perspective when applying this framework. The next topic I'd like to discuss is defining health disparity, health inequality, and health inequity. I contend that it is very important that we be explicit about how these terms are defined in our work. The National Institute for Minority Health and Health Disparities offers this definition for health disparities. That is, a health disparity is a health difference that adversely affects disadvantaged populations based on one or more of the following health outcomes. That is, higher incidence and or prevalence or earlier onset of disease, the higher prevalence of risk factors, unhealthy behaviors, higher rates of condition-specific symptoms, premature or excessive mortality from diseases, and greater global burden of disease using a standardized metric. The World Health Organization defines health inequalities as differences in health status or in the distribution of health determinants between different populations. And health equity has been defined by the CDC as when all people have the opportunity to attain their full health potential and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances. And Healthy People 2020 defined health equity as the attainment of the highest level of health for all people, and achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical contemporary injustices, and the elimination of health and health care disparities. Being explicit about the definition for these terms ensures that everyone on the team, everyone you're working with to address social determinants of health or the reduction of health disparities, knows the definition to be applied. And the definition used informs how those differences are measured. So next I'll talk about measuring disparities. And the next part of the discussion is based on a recent paper that I wrote with colleagues focused on health equity for older adults with cancer, and also a paper called Measurement of Health Disparities, Health Inequities, and Social Determinants of Health to Advance the Support of Health Equity by Penman, Aguilar, and colleagues. So in those papers, the first task related to measuring disparities includes identifying sociodemographic characteristics and social determinants of health associated with less access to those fundamental causes I mentioned earlier, and determine what is of interest in your effort to measure disparities and to advance equity. Some examples would be ensuring that data is collected and available across the range of sociodemographic characteristics, so making sure that you have data available for race, ethnicity, sex, sexual orientation, gender and gender identity, age, socioeconomic status, country of birth, disability status, and geographic location. Another important task related to measuring health disparities is to assess social determinants of health at multiple levels. So if this is in the healthcare delivery context, making sure that you have data at the individual patient level, or the household, that is the patient and the caregiver, the practice level, the neighborhood level, or the full healthcare system level. Another task is to be explicit about your methodological choices. So that is thinking about and being explicit about who is the reference group and why. So when you are comparing different groups, is the reference group the best group rate? Is it the average group, the largest group, the group with the most social advantage, or is there a target rate that serves as the reference? And it's important to be explicit about who that reference group is and why you chose that reference group. Being explicit about whether an absolute or relative scale is being used. So are you reporting the simple difference between rates, that is an absolute measure of disparity, or the rate ratio, that is a relative measure? Another task when measuring health disparities is to recognize within group heterogeneity, that is, individuals have multiple social statuses. So it's important here to determine the intersections of socio-demographic characteristics of interest and where sufficient data is available to do those explorations, such as the intersection of race, ethnicity, socioeconomic status, and sex among older adult cancer patients. Also, to make measurement choices that facilitate communicating with various stakeholders. So it's important that you're prepared to communicate those methodological choices and the results to practitioners, to researchers, and to community members and patients. So next I'll talk about reporting health disparities. So when reporting health disparities, there have been several reports showing differences in health outcomes across racial and ethnic groups. So in this example, it's the Los Angeles Healthy Aging Report from 2015. There were reported differences in the prevalence of chronic conditions, such as African Americans reporting a higher prevalence of hypertension and arthritis, and Latinos reporting the highest prevalence of diabetes. However, would we call this a disparity? There is little guidance for reporting a disparity to ensure that your audience understands the differences. For example, in this bar chart, does this bar chart show a disparity? So the blue bars are diabetes, the red is heart disease, and the green is cancer. And these are the rates across different groups. And so are the differences statistically significant? Is statistical significance the most important measure of relevance here? And which difference is most important, and where should we intervene? And how big does the difference have to be considered a disparity or an inequity? So there are many challenges that arise in thinking about defining and measuring and reporting health disparities. So one, there are many definitions of health disparity. So is it a racial and ethnic disparity? Is it a socioeconomic disparity, a geographic disparity? And also, when is a difference a disparity? That is, how is the difference quantified? And how is that quantification reported and suggested to be used? And if we're using a definition for health equity, and that definition includes a description about things that are avoidable and unfair, who decides, or what evidence determines if a difference is avoidable or unfair? There are also some policy and measurement challenges or implications for measuring and reporting health disparities. So one is, when is a difference actionable? So that is, how big does the difference have to be to warrant action? And should efforts focus on the difference or improving the outcome for the worse off group? And then when can a difference, or when is a difference, ignored? So the example that I presented earlier around prostate cancer differences between African Americans and their white counterparts, those disparities are long-standing. And so how long have we ignored those differences? I often present this quote when I'm giving presentations about health disparities and health equity, and it's a quote from Martin Luther King that highlights the challenges in doing this work. And this is from a 1967 text by Martin Luther King. And the quote is, "There is not even a common language when the term equality is used. Negro and white have a fundamentally different definition. Negroes have proceeded from a premise that equality means what it says and have taken white America at its word when they talked of it as an objective. But most whites in America in 1967, including many persons of goodwill, proceed from a premise that equality is a loose expression for improvement." And one of the reasons that I really like this quote is because I've had several discussions around health disparities and health equity, and it's interesting to note when folks mean, when they're talking about health disparities, when they mean or when they're focused on a slight improvement, or when they're focused on health equity that is focused on actually everyone having an equal opportunity to have their best health possible. And so all of those conversations really informed the development of a framework. And this framework is what I use when I'm working on issues to address health disparities and to efforts towards achieving health equity. And this framework was informed by my teaching a course when I was at the Harvard T.H. Chan School of Public Health called Measuring and Reporting Health Disparities. And it's also part of my experience. I was on a commission for health advocacy and equity in Rhode Island, which was a legislatively mandated body that every 2 years has to write the state health disparities report. And from those efforts, I developed a 3-part case study that takes students through the process of having to write a state level health disparities report. There's a link there to those case studies. But those case studies and in the development of those case studies informed this framework. And so the framework outlines a series of questions to ask as an organization or coalition is working on creating health disparities or health equity content or documents. And the components of the framework begin exactly where we began our discussion here today on health disparities, that is, definitions. How do you define health disparities or health equality or inequality, or health equity or inequity? Next, how do you decide what health outcomes to choose? So if we're talking about prostate cancer, are we talking about prostate cancer prevention, prostate cancer detection and diagnosis, outcomes related to prostate cancer treatment, outcomes related to prostate cancer survivorship, or outcomes related to end-of-life care? Now, surprisingly, this can become a political process when you're doing this in the community, because everyone might or has a particular health outcome of interest. And so some might want to include a focus on prevention, some might want to include a focus on treatment, and others might want to include a focus on survivorship. And we can't include all the outcomes, so there must be a process in place for deciding what health outcomes to focus on. Next, what data sources are you going to use? And in the discussion related to measuring health disparities, do you have the necessary data elements? So if you're thinking about racial and ethnic disparities or place-based disparities, is the data available for to measure those differences? And next, in terms of measurement, how are the differences measured? That is it a rate difference, a rate ratio? Do you just present the graph? So like the graphs that I showed, but will your audience know that that difference that you are trying to present in your graph is actually depicting a disparity? And next, it's important to think about communication. So who is the audience for reporting? So to whom will you be communicating the disparities? And throughout this process, it's important to focus on partnerships, because no one sort of sector can do this effort alone. And so intersectoral collaborations are necessary to address the social determinants of health and social needs and to attempt to reduce health disparities. But the challenge becomes, how do you get all of the relevant sectors to the table to begin the conversation and begin to address the social determinants of health and to reduce health disparities? And finally, what does success look like in this space? And so it's important to evaluate whether or not your effort was focused on disparities reduction or efforts to achieve health equity, what does success look like in those efforts? So here is the full framework. And so again, we go from defining a focus on health outcomes, what data sources are relevant, or what data sources are used. Is it population level data or clinical data? What measures for health disparities are used? Who is the audience for the communication? And who are the partnerships, or what are the partnerships, the intersectoral collaborations that are necessary? And then lastly, what does success look like? That is a reduction in overall rates or reduced differences across groups. It's important to be explicit about that throughout the process for measuring and reporting health disparities. So what are some next steps for the implementation of this framework? And so I mentioned at the beginning that I'm currently the Vice President of Health Equity at Zero, the End of Prostate Cancer. And so in my role as VP, I will be implementing this framework at Zero to focus on reducing disparities in prostate cancer for Black men. And I also adapted this framework in the review paper that I mentioned earlier, focused on health equity for older adults with cancer, and there's a citation there if you're interested in reviewing that paper. So in conclusion, we all know that the COVID-19 pandemic increased attention on the substantial disparities across racial and ethnic groups in health behaviors and healthcare related outcomes, and I'm hopeful that this framework can inform efforts that follow all of the statements that organizations make attempting to achieve health equity. So here's my contact information. If you have any questions about the framework or anything I've talked about today, please feel free to email me at reggie@zerocancer.org.